Good evening, everybody. This is the Glaucoma Society of India Vast Evening. I request the President, Dr. Pandav, to please give the welcome address.
Thank you, Chandrima. Thank you for organizing this unique forum. Basically, we have been having webinars, but I think VAST on Zoom is, I think, purely VAST is for the first time we are doing it, and it's also some kind of an experiment that how we let's see how it goes. But this is going to be very useful, I'm sure, for all the viewers because the speakers we have today are really very eminent surgeons in their field, and most of them are working in institutions where there's a lot of academic and research is there, and also they are very most of them are high volume surgeons. So we'll get to see their videos and learn from their experiences. I'm sure this is going to be very useful for our viewers. I welcome you all to this forum today, and especially our speakers and panelists. So thank you very much for sparing your time, and also I welcome all the people who are joining us online. Thank you very much for joining us, and we look forward to have a great WAS today on digital platform. Over to Chandrima for the rest of the program.
Thank you, sir. So we start right away with the programs because all the speakers and panelists this evening are all stalwarts. So we wouldn't waste time introducing them. All of you know them. So we'll move on with the first video-assisted skill transfer. None other than Dr. Tanuj Dada, learning gonioscopy.
Thank you, Dr. Chandrima. So just let me know my slides and are visible audio is fine?
Yes.
It's visible, yeah, it's good.
So I think gonioscopy is a critical technique, and this presentation is dedicated to the residents of RP Center actually who have worked quite hard to collect all these videos which I'm going to show you. So gonioscopy is primarily required to distinguish an open angle glaucoma from an angle closure glaucoma. That is very critical. On the left side, you can see an open angle. On the right side, you can see the iris coming in contact with the trabecular meshwork and obstructing the angle. So that causes a rise in intraocular pressure. And you can just compare these two videos. On the top is a gonioscopy of an open angle. You follow up from the iris. You can see the ciliary body band, the scleral spur, and the trabecular meshwork very clearly visible. On the inferior video, you can see the iris has occluded the angle structures. So the critical differentiation of an open angle versus angle closure can be achieved with gonioscopy. And this is very important because primary angle closure glaucoma carries threefold the risk for bilateral blindness as compared to primary open angle glaucoma. So whenever you do gonioscopy, you should do it in a dark room with a small slit which should not cross the pupil. And you can use a Goldman 2 mirror to start with. So this is the technique. You try to invert the lower lid and insert the gonioscope. This is the Goldman type gonioscopy being done on the slit lamp. The second technique is the indentation. This is without coupling fluid. This is the Posner lens with a handle. You just put it after topical anesthesia and press the cornea to open the angle. The third technique is the one we use with the Swan-Jacob gonioscopy. This is examination under anesthesia. This is a child with congenital glaucoma. You can see an anterior insertion of the iris. None of the angle structures are visible. And finally, this is the technique to do a slit lamp assisted. This is a handheld slit lamp. This is the Coetis lens. So this is a direct gonioscopy being done on the OT table. So this is a different techniques of gonioscopy. Just to highlight the angle structure, iris, ciliary body band, the white zone is the scleral spur, then the trabecular meshwork, non-pigmented trabecular meshwork, and the Schwalbe line. So when you put in a gonioscope, here you can see the iris, and then this white zone is visible. That is the scleral spur and the trabecular meshwork. Whenever scleral spur and trabecular meshwork, that denotes an open angle. Next patient, again you can see the ciliary body band and the scleral spur are visible along with the trabecular meshwork. So this is a wide open angle visible on gonioscopy. The next thing is to identify the corneal wedge which gives the position of the Schwalbe line. So here you see the two beams from the slit lamp, corneal endothelium, corneal epithelium, they are meeting at this point. So this point is the Schwalbe line where the apex of these two beams is visible. That is the starting point of the angle visible through the gonioscope. And this is the patient. You can see here the wedge apex here, and this is a sine wave configuration typical of the plateau iris syndrome. There's a hump in the periphery which is due to a prominent raised ciliary body. Here you can see a pigmentation, and when you make the corneal wedge, this pigmentation is anterior to the apex. So definitely it's not the trabecular meshwork. This is a completely closed angle. This is looking like a pseudo trabecular meshwork. And this prominent band-like Schwalbe line, see this white structure visible here. This is a very prominent band-like Schwalbe line that is often visible in young patients or with juvenile glaucoma. Now, when you put in a gonioscope and you see dense uniform pigment like this, these are patients who have got pigment dispersion, and especially you can see in the superior angle a very dense uniform pigment obliterating the angle structure. This is pathognomic of pigmentary glaucoma, and nowhere else you will see this uniform dark band of pigment in the angle. This is another patient. Here the uniform pigmentation is less dense. This is a patchy pigmentation, and in between you have small specks of white dandruff-like material. So this is classical salt and pepper pigmentation seen in pseudoexfoliation syndrome. You can see these white specules. That is classic. And then moving on to the angle closure pathologies, here the iris will come in contact with the trabecular meshwork. This is a goniosynechiae, the iris blocking the trabecular meshwork. Here you can see left half of the angle trabecular meshwork is visible, and the right half there is synechia formation. So this is angle closure visible on gonioscopy, and this is the patient of primary angle closure. You can see here this is the trabecular meshwork, and the iris is starting to attach to the trabecular meshwork with dense spattered pigments on the trabecular meshwork. So this is pathognomic of angle closure disease, the development of synechia between the iris and the trabecular meshwork with pigmentation on the angle. Another patient, you can see the synechia formation, the iris coming in contact with the trabecular meshwork. These patients immediately need a YAG laser iridotomy. And as the disease progresses, this is a complete angle closure, no angle structure visible. In fact, this is known as the Mount Fuji sign, and this is due to an anterior displaced lens. Here you can also see the ciliary processes. Now moving on, when you put in a gonioscope, angle structures are not visible. You try to manipulate the gonio lens, and now your ciliary spur has become visible. So this is manipulative gonioscopy being done on the Goldman type lens. This is the appositional angle closure, because on manipulation the ciliary spur has become visible. The same thing you can do with the Posner or the Sussman lens. Here you press the gonioscope on the cornea, push in aqueous into the angle, and then you can see the up of the angle. So this is indentation gonioscopy, and very important, new vessels in the angle. So undilated gonioscopy in diabetics and CRGO patients. This is a new vessels arborizing on the trabecular meshwork. It's a new vascularization of the angle visible in a patient of polycystic diabetic retinopathy and requires immediate cyclopan-retin photocoagulation. If you delay, then you get this synechia formation, and soon the angle will be completely zippered. So do undilated gonioscopy. Then moving on, in some conditions you will get young patients prominent Schwalbe line and very anterior synechia formation. So this is Axenfield's Rieger's anomaly, where you have a very anterior insertion of the iris into the periphery of the cornea, young patient, deep anterior chamber. So this is Axenfield-Rieger syndrome. And these are prominent iris processes seen in developmental glaucoma. You find processes, so there is a again you can see a band like Schwalbe line and an anterior insertion of the iris onto the trabecular meshwork, causing the obstruction. Here you can see trabecular meshwork is not visible. Again, anterior insertion of the iris has failed to recess in the normal development, causing the glaucoma. This is a patient of aniridia. You can see a rudimentary stump of the iris present, atrophic slithy processes. So this is why it is a misnomer, because a rudimentary iris stump is present. And these are post-traumatic angle changes, irregular widening of the ciliary body band visible on gonioscopy. Another patient you can see here, angle is normal here, widening of the ciliary body band. This is a cricket ball injury, and this is angle recession. Another patient you can see irregular widening of the ciliary body band. So this is angle recession visible on gonioscopy, and this is a glass foreign body embedded in the angle. And finally, through the gonioscope, you can see the patency of the trabeculectomy ostium. And this is a patient, there was a shallow AC, and you can see the iris has gone into the ostium, blocking the trabeculectomy ostium. That is the utility of doing gonioscopy. Emulsified silicone oil present in the angle post-vitrectomy. This is the patient of Posner-Schlossman syndrome, very high IOP, featureless angle, and you can see very fine keratic precipitates lying on the trabecular meshwork, from which we could get a clue that patient has a Posner-Schlossman syndrome. And finally, you must learn to do intraoperative gonioscopy. You have to put in these devices into the canal of Schlemm. This is a hydrous implant, so you must learn how to do intraoperative gonioscopy, tilt the microscope and view the angle structures. And last video, this was a patient with a glaucoma. My senior resident got it that, sir, this is a very patient with a very prominent Schwalbe's line. You can see this, which looks like a juvenile glaucoma. So here you can see what he saw, a very prominent Schwalbe's line. And this is the patient on the OT table. So we are doing the cataract surgery, and after that we have put in the IOL. And then when we started doing lens aspiration, you can see this prominent Schwalbe's line was actually large wooden foreign body. Patient had a broomstick injury, and that prominent Schwalbe's line was nothing but a very large wooden foreign body from the broomstick. And you can see I'm having tachycardia and trying to remove this foreign body. So that is the utility of gonioscopy. Sometimes you get surprises. So whenever a patient visits you, must put in the gonioscope, and you can evaluate the marvelous structure of the anterior segment and diagnose glaucoma. Thank you very much.
Thank you very much, Dr. Tanuj, and that was, in one word, mesmerizing.
Thank you.
Would any of the panelists like to ask something at this moment, or shall we move on to the next talk? If there's anything anybody wants to ask, you can ask him.
I think we will just go ahead and then have the discussion later.
Okay, fine. So we move on to the next talk. So Dr. Shumit Chaudhary, laser peripheral iridotomy.
Thank you, GSF, for giving me a chance to speak for I'm totally a video oriented. Before I going further, why should we go for the LPI? Is it necessary? Yes, it is necessary for all glaucoma patients, because without gonioscopy, we do not know which is open angle and closed angle. And as per Tanuj has said,
please share your screen.
Share your screen.
The green icon at the bottom.
At the bottom, green icon. Share. Yeah, that's perfect. Yeah.
Thank you.
This is first I'm showing just 1 minute. Before going for the angle, you should know the Van Herwijk technique to see the shallow chamber is there or not. So I think that there is a narrow angle and the chamber is shallow. It's a Van Herwijk technique first. You can see the central part also. This is the part of the entry chamber, the black one. Very narrow beam. If we go there, then you have to see and confirm it by the gonioscopy. And the gonioscopy is set, you can see this is a narrow angle. All over is a narrow angle. So in these cases, a laser PI will be helpful to this patient. So how should we help? This is the indentation gonioscopy. When I press it, you can see the angles open up, and when I give it loose, it closes. Same thing happens in the lower part. When I do the indentation gonioscopy, the angles opens up, and when I leave it with the normal status, it is a narrow angle. In those narrow angles, there is a chance of more at peripheral anterior synechia and may lead to more damage to the eye. This is what Venkatesh has said, is a doubling of the jumping like that. This is the indentation. You can see the peripheral anterior synechia, small synechia in this part also. And when I leave it, it begins closed one. Same thing, another one cases when I go for the indentation, when I'm pressing it with the Schlossman's lens, the angles opens up, and when I leave it, it gets closed. We can clearly see it, what is happening with the indentation gonioscopy. In these cases, LPI will be of help to us. Another method, when I said, if you put the light on the pupil, sometimes the angle opens up, but it's always. It's not the true one. You have to do the gonioscopy. The same thing, the gonioscopy done at the eye, you can see the dirty angle where the angle is being closed. Now, is it only the angle closer who needs the LPI? No, there's a controversy is that in any cases of pigmentary glaucoma, that some doctors do the PI to avoid all the rushes of the pigments clumping at the anterior chamber and for the to reduce the rise of intraocular pressure. So before going for the LPI, you should just give the biotics to the patient with a pilocarpine 2%. So there is a stretching of the peripheral iris, and you can see the small crypts which are visible where we need the less energy as much as possible. And for this, in many doctors do the LPI without any lens, but most probably the best part, you use the Abraham lens, which has the 66 diopter condensing lens, slightly decentered, which condenses the energy, so you can less energy, we can get a good PI. So the PI is with aiming being on the crypts, we just give up shots. You can see the dirty fluid coming out of the again second shot, you can see the dirty fluid. So which is the ideal? Ideal it should be if we give the PI, if we put the laser in the iris, in the crypts, you can see the pigments dispersion from the crypts is coming to the anterior chamber, and that is you have put a through and through laser point, and you have disrupted the rectal pigmentary epithelium, which is the darker part, and you can go for the through and through. But the main point has to be there, how much? If we go more peripherally, it will damage the anterior capsule. If we come to the anterior chamber, more decentration, it will damage the corneal endothelium. So it has to be the perfect position towards just at the iris crypts. Another point is the peripheral iris. You can see the crypts. There's a PI has been done here. You can see the small laser. So this is the ideal cases of doing the PI. And there are lots of controversies are there doing a PI, and post-operative we can do what we should give normally steroid drops at least 4 times a day for at least 7 days, and go for the intraocular pressure checkup after 1 hour doing the PI, and the next day if it is possible. But definitely within 7 days to see the intraocular pressure and also do a gonioscopy and see the status of the ankle of the anterior chamber. And if the pressure is a little higher, you can give the anti-glaucoma medication, which is before you were giving the apraclonidine, some doctors give the brimonidine tartrate, whatever needed. You need to lower the intraocular pressure, see the pressure, do the gonioscopy, see the patency of the PI, and then you can follow up the patient for the next treatment. Thank you.
Thank you very much, Dr. Chaudhary. Thank you very much. That was a very detailed description of the laser peripheral iridotomy. And we'll move on to the next talk, that is Dr. Rajul Parikh to speak, to show a video of needling.
Needling. Thank you, Dr. Chandrima. So is visible?
Yes, it's clear.
So I thanks GSI for the invitation. I'll be talking about the bleb needling. We are doing trabeculectomy left, right, and center, and everybody must have realized that we want ideal perfect bleb, but it doesn't happen all the time. The perfect bleb happens small time like this, where we have the space between the conjunctival epithelium and sclera nicely elevated. Lots of time we have a flat bleb or overfiltration of the bleb. I'm not going to talk about the overfiltration. I'll concentrate on the bleb, flat bleb. Now this is the ideal bleb, a diffuse, not a localized, multicystic, a very few vascularization or very minimal, and this is the bleb failure causes. And I'm going to concentrate only on the subconjunctival and episcleral fibrosis. The other causes like tight scleral flap sutures or the internal ostium, that when we do gonioscopy with Tanuj and Sumit has already discussed, we can pick it out. And the tight scleral flap sutures, of course, has to be taken care before we do the needling. Now, what is a failing bleb? It's flat, the extent becomes limited. We have lots and lots of corkscrew vessels. The bleb becomes thick or encapsulated. The microcyst disappears, and the later on the IOP rises. The only IOP rise is not the criteria. So in those cases, when we have taken care of other factors, we'll do needling. It is done the topical, or if the patient is uncooperative, we can give the small periburbal block. 26 or 30 gauge needle. I use 26 gauge needle with the tuberculin syringe, and the needle we have to introduce a little bit beyond the bleb. Now the cutting the fibrous to and fro, back and forth sweeping motion is very important, which I'll show in the video. And if there is no aqueous flow, then we have to enter in the anterior chamber. Those are the videos I'm going to show. Now we can use the different antifibrotic agents. I use only mitomycin, and I bend the needle like this 45 degrees. It gives me much more comfort. I inject 0.01 cc diluted into 0.04 cc of the distilled water. I have entered from beyond the bleb into the intrableb area. I inject this 0.01 cc diluted 0.04 cc of mitomycin in the bleb. I wait for 8 to 10 minutes. After 8 to 10 minutes, with this 45 degree bend needle, I enter in the bleb, and you can see this is the to and fro sweeping action. This swiping action is very important to cut the tissue, the fibrous tissue we have to cut. And lots of time we may have to enter and re-enter from the different positions to cut the issue. You can check that how much the IOP is reduced. It may not be necessary all the time. Sometimes it will bleed, and that's why I kept this video to show that because it's a congested bleb, it may bleed. The swiping action to cut all the fibrous tissue is important. Now I have gone into subscleral area, and then you enter in the anterior chamber if necessary, which I will just show you. Now in the subscleral, I have made my needle little bit perpendicular, and I am in the area, and yeah, I have entered in the anterior chamber. Now this is the swiping action. Subsequently, you can, and this video I kept because I have not injected mitomycin, just to show. I can show you the swiping action of the needle very clearly. You can see here, you have to cut to and fro and cut the fibrous tissue very nicely, because if you don't cut this fibrous tissue, the needling procedure is going to fail. So this procedure of cutting the fibrous tissue is very important for the management of the failing bleb. Once you have done that, and if you feel that the anterior chamber, the IOP is not reduced, or if you want, you can go to this is the subscleral space between the flap, and then you enter in the anterior chamber. So you have opened up the subscleral fibrosis and you enter in the ostium also. You can do, and I don't do routinely, but you can enter in with the side port and do the hydrate and see that how much the bleb forms. I routinely don't do, but this is I just kept for the technical purpose, just to show the audience. Now this is my friend's video. You can see he uses the large needle. When you use a large needle, there is usually a conjunctival tear. If you've done the needling, if there's a conjunctival tear, please make sure to suture that bleb, because you want the failing bleb to be working, not leaking. So if the bleb starts leaking, then you are in another problem. So please suture with the tenon needle very clearly. Of course, you can do one thing, that you can either bury or you can trim it very nicely, so the patient does not have much the foreign body sensation which the knot is open and big can have. So those things we have to take care. Now these are the different. I use mitomycin. You can use only 5-FU. Some people don't use any antifibrotic agents, and then they use post-operatively 5-FU injections in the OPD. I am more comfortable, and my success rate is much better with the mitomycin, very diluted. Now here, just to show that you can check the leak, you can use the fluorescence strip under the microscope and check for the leak. Now this is my patient, pre-operatively flat bleb. This is 1 week, this is 3 weeks. You can see that the bleb is very nicely elevated. The vascularization is reduced. I had given a couple of 5-FU injection post-operatively also. In the same patients, ASOCT, to show a very nice subconjunctival space. So this is the ideal bleb needling. We don't get the success rate of 100% post bleb needling. The success rate around 65-70%. Usually I will not take the needling in the first month. Usually I will do other assessment like the suturolysis, and at the end only I will do needling. Now Dr. Sushmita was telling that she is not going to show the over filtering bleb, the bleb distresses. You can see this overhanging bleb on the pupillary axis. So I thought I'll just show a very small video that the excision of the bleb is usually a very simple thing. If it is overhanging, if it is causing visual disturbance, because it can cause a severe astigmatism or severe disturbance because of this overhanging, the patient may have severe dry eye. In those cases, we may have to dissect. The dissection is a very simple thing with the in the overhanging bleb. Usually they are in the one plane. Most of the time, the overhanging part may not be connected to the main bleb, and you can just dissect. Now this I am going to do a big dissection because this patient had a very avascular bleb, and actually it had a scleral thinning also. I'm not going to show that because Dr. Sushmita will show all the other bleb related videos. Thank you.
Thank you, Dr. Rajul, very much. Those were indeed excellent videos of needling for failing or failed blebs. And with that, we'll move on to the next one. The next one, Dr. Shanta, are you going to speak live or should we play your video?
Can you play my video, please?
Okay, yeah. So, Bhageshwar, you can play Dr. Shanta's video. There's no sound. Bhageshwar, there's no sound. There's audio. I heard it.
Relatively avascular and microcystic. The barriers to achieving such a bleb include surgical trauma, conjunctival inflammation, fibrin formation, growth factors, and cellular proliferation and scarring. Careful preoperative preparation, use of atraumatic surgical techniques, and judicious use of cautery can minimize surgical trauma. Anti-scarring agents such as 5-fluorouracil and mitomycin C are popular, and patients who require surgery can be categorized into low-risk, intermediate, and high-risk groups in order to decide which antibiotic to use and what concentration to apply. Mitomycin C was isolated in Japan in 1954 from Streptomyces cephaloposus. It causes almost a complete inhibition of fibroblast proliferation and has a toxic effect on the ciliary epithelium as well. Factors influencing the efficacy of mitomycin C include the dose delivered to the tissues, volume, duration of application, the mode of administration, the effect of the sponges and variability in drug delivery, the surface area of application, and the location, that is subcutaneous versus scleral flap or both. Most of the toxic effects of mitomycin C are related to hypotony-related complications, which are dose-related. The routes of application include the use of sponges or subconjunctival injection. The appropriate dose and the duration of application has to be decided. Count the number of sponges being applied. They applied well under the conjunctival surface, away from the limbus, pushed posteriorly, and placed in situ for about 1 to 3 minutes, depending on the risk factors, following which the sponges are all removed and copious irrigation with normal saline is required. The problem with sponges, you can lose them, you can get retention of sponge fragments, damage to the conjunctiva during manipulation may occur. There is a physical barrier to treating a large surface area which would be ideal. Variable amounts of saline irrigation use can result in variable delivery of the mitomycin. Therefore, subconjunctival injections are now becoming popular, and this was an RCT which looked at the results. The advantages of injection are you avoid limbal stem cells, you can achieve a posterior diffuse spread with precise control on the amount of drug being used. The 36 eyes in the injection group were compared to 37 eyes in the sponges group, which were followed up for 3 years. In the injection group, 0.1 ml of 0.01% of mitomycin C was injected into the area of the trabeculectomy and spread posteriorly using a blunt spatula. The conjunctiva was opened after 1 minute, and muzzle hook was used to tease out the mitomycin C from the tenon's tissue. Sponges were used with mitomycin C 0.02% applied for either 1 minute or 3 minutes. Failure occurred more frequently in the sponges group, as seen here, and the blebs were also more diffuse, of less height and less vascularized than the sponges group. The duration of mitomycin C extends the window for postoperative titration of intraocular pressure using either releasable sutures or argon laser suture lysis. And you can see that after argon laser suture lysis has been performed in this patient, you get the appearance of a more diffuse and elevated bleb. So even as late as 34 to 38 days following laser suture lysis, which was performed in about 136 eyes, either the removal of 1 suture, the removal of 2 sutures, you can see that there's a significant drop in intraocular pressure. However, hypotony-related complications may occur. And this was a patient who developed a suprachoroidal hemorrhage following late laser suture lysis 6 weeks following surgery. And this was a devastating complication. Late blood leaks in this patient as late as 9 years following surgery have also been described. Hypotony maculopathy was reported in eyes in which antimetabolites were used by Robert Stamper, and you can see the folds in the posterior pole, which are nicely picked up with the Swepsos OCT. The use of adjunctive antimetabolites increases the incidence of blebitis by 1% to 3% per patient year, and these are some of the risk factors which have been described. Therefore, the judicious use of mitomycin C involves careful preoperative evaluation, use low dosage and duration of application, use a wider area of application, fornix-based conjunctival flaps are preferable, removal all sponges at the end of application, use injection if possible, and avoid the post-operative use of contact lenses. Ologen was brought into place as an alternative to the use of mitomycin C in order to achieve the same results without the complications. And this is available in 2 sizes, 6 millimeters and 12 millimeters. 6 millimeters is used for trabeculectomy. It is composed of more than 90% atylocollagen and less than 10% glycosaminoglycans. It serves as a spacer and provides scaffolding to modulate the fibrotic response. Only releasable sutures can be used with this technique. Usually one releasable suture alone is used, a little loosely applied so that you can get an immediate flow of aqueous from beneath the scale flap in the early postoperative period. So this is the appearance 9 days following the use of the Origin, and you can see that there's a diffuse elevated bleb. This was a study which compared the CM matrix implant versus mitomycin C in trabeculectomy at the end of 5 years. And patients were assigned to either trabeculectomy with mitomycin C or 2 minutes or the use of Origin. The preoperative demographics and diagnostic criteria were similar in both groups. You can see that the appearance of the bleb is much better in patients in whom the Origin has been applied. The intraocular pressure data was similar at the end of 5 years between the two groups. However, the bleb was diffuse and spread out with the Origin compared to the mitomycin C group. Complications were similar between the two groups, but Delin formation has been described with Origin. Therefore, it's important to match mitomycin dosage and duration of application to the risk factors for failure. Timely postoperative titration, prompt recognition of hypotony with appropriate management, patient counseling with regard to risk of infection and follow-up is mandatory. Patient counseling is important. Avoid splashing of water into the eye, avoid swimming, or use protective goggles, use protective shield in susceptible eyes, warn about early signs of blebitis and endophthalmitis, avoid use of prophylactic antibiotics, and avoid use of topical steroids. Thank you.
Thank you, Dr. Shanta. That was a very detailed overview of the trabeculectomy adjunctives. And we'll move on to the next presentation. That's Dr. Ankush Mahajan on canaloplasty. Dr. Ankush, you are here. Yeah, you're there. Yes. Can you share your screen and start, please? Dr. Ankush, are you there?
I'm there.
Yes.
I have some problem with sharing screen. Can we move on to the next speaker and maybe I can
move on to the next speaker while you get your or if you send your presentation across, we can play it from the technical team. Whichever is suitable. So then we move on to Dr. Shushmita Kaushik with the bleb revision.
Yes.
Yeah. You can mail your presentation to my email, Secretary GSI, and I'll send it across to the team. You have my email, the one from which the link went?
Yeah, I know it's a video, so it will be a big file.
Oh, it will be difficult?
Yeah, I can start on the next presentation. If you'll go ahead with the one presentation, I'll share.
Okay, that's perfect then. Okay, we'll go ahead with Shushmita. Yeah.
No, I seem to have lost my video. Just give me 2 minutes.
Okay, that's fine. That's fine. So while we are waiting,
meanwhile we can take the questions.
Yeah.
It's come up.
Okay, carry on.
Is that visible now?
No, not yet.
Share your screen.
I did open it. Okay, just take one question. I'll just open it. Something else.
Okay, this question is to Rajul. Do you do needling in OPD or OT? Is it not very risky to inject MMC if you are entering the AC?
I do needling in operation theater only, and I am using I think the 0.01 is too much diluted mitomycin because we use 0.02. So 0.01 diluted mitomycin again diluted with 0.04 cc of distilled water is a very diluted mitomycin, and this was described way back in 97 when I was a resident, and I'm using since 97 and I never had any complication. So I think it's very safe. Second, if there are described technology that if you are really worried, then you can use the Helon or high visco material in front of the before you inject the mitomycin. So the visco material will not allow, and the high molecular will not allow the mitomycin to get drained into the NTA chamber. But I have never done that. I never felt the need to do that. So I am doing that for, as I said, more than 20 years, and I never had complications. It's very safe.
I think it also depends on where you inject it. So do you inject it straight into the bleb, or you know?
I inject in the bleb.
In the
bleb. But as I said, 0.01, the initial dilution of 0.02, I take 0.01 cc, dilute again with 0.04 cc of distilled water. So once you do the dilution, so it's literally 0.002 cc. So it's very diluted, very diluted mitomycin. And if I remember, I have not read recently, but if I remember correctly, I think the histopathological studies have shown that it is not toxic to the cornea. It's too diluted.
And also,
I don't know what other people do.
Actually, inject in the subconjunctivally, then it doesn't get into the bleb area. Actually.
It can. I absolutely agree, Dr. Pandav.
So
it can, but I do it at the slit lamp. Actually, I always do needling at the slit lamp. I don't take the patient to the OT, and not that all my blebs fail, but then I've been doing it quite often at the slit lamp, and it's quite all right. Actually, whatever you're used to, I think that's what matters. Anybody wants to add anything?
I don't.
The literature has suggested to use lidocaine 1% or 2%. So I just want to know whether you are using distilled water or you're using lidocaine also, because there is some change in pH of mitomycin, say if lidocaine is being used. So I just would like to know what is the practice.
I use distilled water because that is what is described originally. So I don't know.
I think for my MMC, actually it comes in a salt solution. So best to dilute is actually the sodium chloride as a normal saline, because the bile of the MMC actually it has a salt in. So when you reconstitute it with distilled water, it actually becomes like a normal saline plus MMC. So further dilution would be better done with the normal saline, but it could be done with the distilled water also. Okay. Combining with the lidocaine, I'm not sure is a good idea. I remember offhand once I tried doing it, and in the syringe I noticed that there was a little bit of precipitation.
Yeah.
So there was something was not right, so I discarded that and actually went back to my original procedures. Though I haven't retested again, that might be by chance or something, but I didn't do that again.
Okay.
I think regarding location of the injection, I think the message should be very clear probably that we should inject in such a way that the drug does not enter into the anterior chamber. That's what actually we have been taught, and I personally use it. I inject it away from the blade, maybe a centimeter away from the blade. And another thing I would like to request Rajul to inform us, whether you inject the drug at the beginning of the surgery or towards the end of the surgery.
Yeah, I inject beginning of the surgery. Then I wait for 7 to 8 minutes for the mitomycin to start acting before I start my needling. And as you said, injecting away from the bleb, there are different techniques described. I inject in the bleb because that is it's a described technique. There are described technique of injecting away from the bleb also, as Dr. Panda was pointing out. So when you dilute, and it's very important, I will again repeat, I am not using 0.02. I dilute 0.02 further by using 0.04 cc of distilled water, and I take only 0.01 cc of mitomycin. So it's a very highly diluted solution. So if you are not going to do that, then you will have lots of side effects. So the key is, if you are going to inject in the bleb, then it has to be diluted. That is very important.
So do you use the same concentration for the early bleb needling and the delayed or late bleb needling?
Yes.
Same concentration?
I inject in the bleb. So it's very important that I use diluted mitomycin. So that's why I use the same diluted concentration.
Okay. So we're ready to go, Shushmita?
Yes. So it's visible now?
Yes.
Yeah, okay. Right. So today I'll be at the outset. Thank you very much, GSI, for the opportunity. Trabeculectomy is not as we'd like it to be, and we'd like it to look like this diffuse normal bleb with a wide open sclerostomy. And what we definitely don't want, and we can predict and manage in time, are blebs like this. So glaucoma surgery, we must remember, is a journey that has just begun. And try as we might, we present here are some stories of the journey beyond the initial trabeculectomy, because that is what is important. So the first situation is the IOP is high. We don't just prescribe drops. We must see what the problem is. For instance, in this case, with a high IOP and a peaked iris, the first thing to do is a gonioscopy, and we can see the iris stuck in the sclerostomy. So this is a small clip showing retrieval of the iris, which is stuck in the sclerostomy, and then we need to enlarge the PI. So the first thing that was done was pulling the iris by an ab interno approach, and then used a vitrector to enlarge the PI. So basically the PI was not large enough to straddle the sclerostomy, which is why it's stuck in, which is important to while doing the surgery. And once the PI was visible, you can see post-operatively the sclerostomy was free of the iris and the pressures were better. So Rajul has already looked at the scarred or failed bleb. So this is just a small clip which will show the needle revision. The same thing, but another technique. We go again in. This is on the microscope table, but there are early bleb needlings we do on the slit lamp. So for a late one, I find more control if we take the patient to the OR. And you can see here it is pretty much scarred. So sometimes we have to be very, very careful, but we also have to be slow, because it's very easy to go through it and come out on the other side. So you can see the whole eye really is moving, but I tried to hold it, but the conjunctiva was so friable. Well, you can see this post-operatively, you can see the fluid fill there. But the other possibility nowadays is of an ab interno bleb revision, and this is to re-establish aqueous flow. The prerequisites are open sclerostomy site, and this surgical technique basically is using this new Grover Filman spatula, which goes across, and we'll just see in a minute. You're doing the same thing, but basically you're doing it ab interno. So especially if the patient is faking, we like to put in a bit of pilocarpine, so we have more iris, which is covering the lens. And this is an indirect gonio lens used to just visualize the sclerostomy a little bit. And once we see that, and the spatula goes into the sclerostomy opening, and once we are sure we are inside the sclerostomy opening, because we don't want a false passage, then the lens is removed and we start the revision procedure, as it were. So the difference here is that we are actually going under the scleral flap and then going across the scleral flap to come out under the conjunctiva. So there must have been a bit of fibrosis under the scleral flap here as well. So you can see this blue spatula going through and through, and in a couple of moments you'll see this blue thing which has come out here. So it's come out, and you can see the blue of this come under the conjunctiva, and then you know that you've traversed it, and then it's a little easier. So this is post revision day 14. You can see the conjunctiva is not violated externally, so it's cleaner. And day 28, it looks like almost normal conjunctiva. So we found it very useful. The other scenario is low IOP. That is also a problem, and that also requires a revision. So this patient, for instance, had 4 millimeters, and as glaucoma surgeons, I think the hypotony is more troublesome. 624 vision with hypotony maculopathy with striae, and so we decided to try compression sutures. There are lots of ways that we've learned, but one of them, which I find the easiest and effective also, is just pretend that the conjunctiva is not there. So we just go in, and I found Nino nylon sutures a more useful suture to tie this, and we just make additional sutures into the scleral flap, and believe you me, within 2 weeks this will just disappear into cheese wire through the conjunctiva, and we won't even know where it was. So that's the principle. We just pretend. So since I make a triangular flap, delineate the flap under the conjunctiva, and it is a little bit of a blind procedure, so you need to be a little careful that you're not going in, but it's easy enough to go through both lips of the sclera and come out on the other side and then tie it tightly. So this is the most non-invasive way of revising a low IOP bleb, and often works, and saves us having to open up the whole thing and revise it again. So once the knots are tied, and we do make it pretty tight here, you can see already the bleb height has come down because it was there, and the extent has come down. And here you see the height is reduced, the vision comes back to 612, and the IOP also rises. The other scary thing is this thin, cystic, sweaty bleb, which I don't like to leave. So here basically this bleb is not functional at all. So what we do, what Dr. Rajan showed, we'll just excise this unhealthy bleb and replace that bleb area with healthy conjunctiva, which is undermined all around. One thing to take care for blebs like this, because it might be very unpredictable, I keep a scleral patch graft ready in the OR. Many times when you excise this, you realize that the sclera has also become very, very thin and friable, and you might have a show of the ciliary body there. So in that case, it might require a little bit of tectonic support, but in this case, there wasn't. So we just excised it and then brought down the conjunctiva, the healthy conjunctiva, and closed this area. So this itself works because that little bit of fibrosis helps in opening up, helps in building up the pressure a little bit. So this is at the end of surgery with the undermined conjunctiva just covering this area, and the bleb does remain functional after that. So this is just a tight suture at the end. This is how we usually just give 2 tight mattresses at the end of all our convex-based flaps, which is what we're doing. So this is what it looks like. To summarize, trabeculectomy is the beginning of a process, and the post-operative period involves many, many adjustments. Each of the interventions has a specific role, either in isolation or combination with other interventions, and recognition of bleb morphology is the basis of intervening appropriately, but it is sobering that despite close monitoring, some trabeculectomies eventually do fail. Thank you.
Thank you very much, Dr. Sushmita. As usual, really excellent videos and truly engrossing, excellent surgical skills. So with that, we'll go back to Dr. Ankush. Are you ready?
Yeah.
So what Bhageshwar says is that you could put off your video if there's a internet connection problem.
Yeah, it's fine. It's fine.
Okay.
So is it visible, the video?
Yes, perfect.
Okay, fine. So canaloplasty as a technique has been there since 2000. In fact, it took a lot of interest people took in it after 2000. So this has been going on outside in Western countries. In India, a few doctors are taking interest in this. Thing is that you don't get many opportunities to perform this surgery in India because the problem is that we have a lot of narrow angles here. So not all people are good candidates for this surgery. So this is just a video, but through this I'll go ahead and talk about all the finer points about how to do this and what are the pitfalls. So one important thing is you do need a double traction suture like this here, because the central part of the traction suture helps to keep the superficial flap in place later on. Secondly, conjunctiva you can open up anyway as you do your trabeculectomy. I prefer to keep a little frill of conjunctiva superiorly, but that is not very specific to the technique as such. You can leave the frill there, or you can just do it as you do your trabeculectomy. You don't need to dissect it too much. You don't need too much cautery. In fact, it is preferable that you leave some perforators there and not just coagulate everything. Flap can be made either as a rectangular flap, triangular is not preferred. Preferable is a oblong flap like this, because usually in this we don't want a conjunctival fluid egress after the surgery. So oval flaps like these close much better than rectangular or triangular flaps. Second thing, when you are making a superficial flap, you need to dissect a little bit more into the cornea. So normally I go at least 0.5 to 1 mm straight into clear cornea with the superficial flap. And like I said, the upper part of the traction suture helps in holding the superficial part in place when you're doing it. The superficial flap needs to be a little large than your regular trabeculectomy. So here, I normally prefer my flaps to be around 4.5 by 4.5 mm. The superficial flap goes to a depth of around 300 to 350 microns. The deeper flap is below that. Again, you start with just a scratch incision to delineate where you are going to do it. And this deeper flap has to be dissected under the highest magnification that you can get in your microscope. So I normally use around 26x magnification of the microscope. And how to recognize the plane of dissection is that you usually cut down straight and stop at a level where the bluish uvea is visible with overlying sclera, and that is a clue. Once you see the uvea, you just move your blade a little anterior to it and then start further dissection. And you have to operate at the highest magnification, at least 20 to 26x. So I go straight down. As soon as the uvea is visible to me, I go a little few fibers anterior to that and then start dissecting. And this is the most important point. If you don't follow this principle here, there are a lot of times you will not end up opening up the canal. So in order to maintain a correct plane, it is important to you start correctly at the right plane. And your assistant can keep the bleeding and the fluid away using a Vexel sponge. You might get cases where there's a lot of bleeding, but then again, it is preferable to use adrenaline to stop the bleeding rather than doing overly excessive coagulation of those blood vessels. So like I said, you go up to 95% of the scleral depth with the deeper flap. So you can see here the uveal fibers visible, and I go just anterior to that and then go anteriorly in a single plane. And one trick to maintain the plane is that you cut the sides first and then dissect later, rather than dissecting in the center and then cutting the sides later. That helps you keep the plane straight in one single plane. And as soon as you identify the scleral spur, so here you can see the fiber orientation has changed. The fibers are more horizontal, white. This is the scleral spur. So I stop normally as soon as I've identified the scleral spur, because this marks a change in the further. This is another case to show this is the scleral spur and you stop there. So this was a combined case. If you're doing a combined case, then you need to stop before the scleral spur. Even if you're not doing a combined case, then also you need to stop before, right at the scleral spur and make a side port. Now this is important because there are two components to this surgery. The first component is done under a slightly higher pressure in the eye, and the second component of the surgery needs very low pressurized eye. So how do you recognize the canal? How does the canal appear when you have cut through it? So you get a gush of blood with fluid as soon as the ostia of the canal are exposed. And usually one clue is that the canal is just anterior to the scleral spur. So like here you can see, as soon as I cut, you can see a gush of fluid. This is the gush of fluid coming out through the ostia. Now this tells me I've opened up the ostia there, and this flap which I was removing was the inner wall of the canal. And next step is catheterization. You need an illuminated microcatheter to catheterize the canal. And this catheter is around 250 microns thick, has a central lumen with which you can inject viscoelastic. Now, how do you catheterize? This is important. If you see the orientation of the catheter here, it is not oriented in the shape of the cornea. So you need to orient the catheter along with the cornea, otherwise you will have difficulty in catheterization like I am having right now. See, I'm not able to, I am feeling some force in the movement of the catheter. So I asked the assistant to move the catheter towards the corneal curvature, and then the catheter can easily move. Second trick is that you need the eye under a little high pressure when you are catheterizing. If your eye is hypotonic at this stage, you will have a lot of cases where the catheter can get stuck and you won't be able to catheterize the whole canal. So while catheterizing, you need the IOP to be slightly higher, at least in normal ranges. Next step is to tie a 90 Prolene suture to this catheter. So the surgery is to tie a suture to the catheter, pull the catheter out, the suture lies in the canal, and the suture is tied tightly so that the canal is dilated because of tension of that suture. So this 90 is tied with a 2-1-1 throw. You don't use more than 2-1-1 because otherwise the suture will get stuck in the canal or the catheter will come out without the suture. So once the suture comes out, then you need a little further dissection because the second component is exposing the Descemet's window. You need to create around 500 microns of exposed Descemet's membrane through which fluid can egress out of the anterior chamber. So you don't do this before catheterization because the eye will become hypotonic and then you won't be able to catheterize. Now this step is very important for creating the Descemet's window. I'm using a Vexel sponge and this is done under a hypotonic eye. So I've already lowered the pressure. Now I'm using a Vexel sponge to push the cornea down so that the DM is detached from the Schwalbe's line. Now you get some space for dissection. It is very easy to dissect after this. If you don't do this step, then a lot of cases you will have a ruptured Descemet's membrane, which can be a problem to handle because of the hypotony and the shallowing of the anterior chamber after that. So if you are able to detach the Descemet's membrane, then there is no problem. You will never have a Descemet's rupture after that. So you excise the deeper flap. And this is the most important part of the surgery, which I feel, tying the suture under adequate tension. So you don't use a 10-0 because it will break easily. So I use a 9-0 Prolene, and ideal way is as soon as you tie, the edges of this ostia should oppose a little, and that is an indication that the tension is good. So you go with a 4-2-1 throw, and then you can add further 1 throws if you want to lock the suture in place. This is under high magnification. So you see the ostia should come near 1 year time. That is important. And once you have done that, there's a small snapback test. You can just pull the suture a little and see that the knot immediately snaps back to the Descemet's membrane. So that will show you, yeah, yes, tension is right, and you leave it inside. So you trim the knots. This was a one-eyed patient, so I was using Olezin as a space maintainer in this under the flap. And you have to at least tie 4 to 6 sutures on this flap to close it down. You don't want any fluid egressing out of this flap, because if the fluid egresses out of the flap, the whole mechanism of the canaloplasty surgery fails. So this is a surgery where you don't want any blebs. So these sutures are tied tightly, all the knots are buried. That is also important so that you have the least possible vascularization of the conjunctiva later on. And you can close it as any way you like. So normally I use a running hand suture, and you can close it lightly even if there is a little gap in the conjunctiva. It's okay because you don't have a bleb. There is not going to be any leakage from this part. So I normally leave a little air. I used to leave, in fact now I don't. You can or you may not leave the air inside. It is up to you. Doesn't serve much of a purpose after you have learned a few tricks. So it has a big learning curve. So you'll need to do at least 10 to 12 cases to get a good hang of it. The first 10-12 cases can be a little difficult. Post-op steroids are to be used for a month if this is only a canaloplasty procedure alone. Or if I do a combined procedure, I use it for 6 weeks. Suture removal at 10 days, and usually this will cause around 2.5 diopters of with the rule cylinder to the patient. So you need to tell your patient that refractive error changes will be there, but those will revert back after 2 to 3 months. Thank you.
Thank you very much, Dr. Ankush. And I'm sure everyone else like me was glued to the computer screen watching your video. It was truly mesmerizing. And once we finish off with the presentations, I'm sure you would have a bunch of questions at you. So for the present, we'll move on with the next presentation. Dr. George, patchless tube implant.
Thank you very much, and good evening, everybody. So Professor Paul Palmer from Bascom Palmer Eye Institute, during one of his visits to Madurai in 2015 to assist with the surgical training of the non-valved Orolab aqueous drainage implant, suddenly started advocating tube implant, patch-free tube implantation. And he kept referring to this paper which appeared in the Indian Journal of Ophthalmology about 10 years back from the Felix Gil group from Mexico, where they published their results of 128 eyes who underwent Ahmed glaucoma valve implantation through a 23 gauge needle generated scleral tract without fashioning a scleral flap or using a donor patch material to cover the tube. And they had tube related complications, like they had tube retractions, they had tube lens touch, tube corneal touch, but the highlight of the paper was they reported no tube extrusions or tube exposures. So coming straight away to our technique, after making sure that the episcleral plate is positioned adequately posteriorly, the tube is draped over the cornea, and 2 millimeter anterior to the limbus, a mark is placed. And at the mark, an anterior bevel is fashioned on the tube. Again, the scleral groove, the point of initiation of the scleral groove is also clearly marked. This is 4 millimeter posterior to the limbus and 2 millimeter medial to the original position of the tube. This is important. We'll come back to this later. We are prejudging the point where the scleral tract has to change abruptly from initially it is going to be parallel to the tract is going to be parallel to the sclera. At the limbus, it has to abruptly change to become parallel to the iris. So that bent 23 gauge needle is used to initiate the scleral tract at the scleral groove. We aim to get about 50% of scleral thickness as confirmed by visualization of the needle throughout the procedure. So this is the point where the point where we had already prejudged, and here is where the needle track abruptly changes to make it iris parallel. So here counter traction is applied by your corneal forceps, and the eye is rotated from a little downward position to looking straight ahead, and this facilitates the surgeon's view, and he can make sure that the needle is, the entry point is parallel to the iris. So again, very carefully withdrawn so that you don't damage the track or enlarge the track. And then the tube is threaded through this narrow scleral tract into the anterior chamber till it is visible in the anterior chamber, confirmed by about 2.5 millimeter tube which is visible in the anterior chamber. So threading the tube through this narrow scleral tract can be challenging initially, but these long scleral tracts are usually self-sealing, and it's always amenable that you can always make a second scleral tract if necessary. So that is the tube in the anterior chamber, and we should ensure that this is at least 4 millimeters. Slightly more the better. And it's also imperative to cover the conjunctiva well, making sure that you have also including the Tenon's fascia below. So the advantage of embedding the tube in the sclera is that the ocular surface is much less elevated, there's much less of inflammation and much better wound healing response. But an important caveat is have a scleral tract of adequate length and depth so that the tube is well buried in the patient's own sclera. So multiple reasons have been postulated for the reduced risk of tube exposures. One is that the tube has a snug fit in this long scleral tract. Micro movements and aberrations are minimized. Again, there is a much flatter transition at the limbus from the conjunctiva to the cornea. Again, the tear meniscus, the lubrication is much better, and this is also another possible reason for the reduced risk of tube exposure. So what we have done is how we have modified this Felix Gil technique is we have accurately marking the tube, accurately measuring the initial scleral groove, and this ensures an optimal 2 millimeter length of tube in the AC and a minimum 4 millimeter scleral tract to cover the tube. Again, for both the right and the left eye, we initiate the scleral tract medial to the original position of the tube. Tube enters the eye around 12 o'clock. It's an initial sinuous route, and they say the tubes entering the anterior chamber at 12 o'clock have the minimal possible contact with the eyelid. Another reason for probably reduced risk of tube exposure. Again, incidentally, we also found that in case we need a secondary intervention, like if there's a tube retraction, a tube exposure, or a tube corneal touch, we have adequate length of tube still available to reposition the tube. Here was a child who had a tube retraction, and we were able to reposition this tube without help of tube extension devices. So as this is already mentioned, prevents micro movements, and another potential advantage is late tube straightening is also avoided because the resistance to the straightening is distributed over much wider length of the scleral tract than if it had been much smaller. So we have also described our surgical technique and published our results in the AJO earlier this year, and we have concluded that RD placed without a scleral patch graft is as safe and effective as RD placed with a patch graft in pediatric and adult refractory glaucomas. So this was a retrospective comparative interventional case series, 215 adult eyes, 111 pediatric eyes, minimum follow-up of 2 years, 147 adult eyes in the patch and 73 pediatric eyes with the patch, 68 no patch in the adult group and 38 no patch, minimum follow-up of 2 years. There was no differences in the groups in terms of intraocular pressure, vision, IOP lowering medications or complications. And what was again interesting was the tube exposures were all noted in the patch group, 2 in the adult and 7 in the pediatric. Adult was occurred in the 1st and the 6th postoperative months, 5 eyes within 1 year post-surgery in the pediatric group, and 2 at 3 and 4 years. And I'm sure most of you would have seen this. It's not that the patch grafts stay there. Some of them do melt, and we see that the tubes stay beneath the conjunctiva throughout the life. These scleral patches can melt too. And some of the practical tips is ensure, this is very important, ensure correct positioning of the plate before marking the tube. Suppose artifactually the plate is a little anterior and you mark the tube and you find that the tube is shorter than what is adequate. An upward lift on the syringe through the scleral tract ensures once you get 50% depth of the scleral tract, an upward lift on the syringe ensures that you don't go too deep and you don't get into the sulcus. This is very important. Prejudging the point of transition, I'll come to this a little later. A good anterior bevel definitely helps with threading the tube into the scleral tract, and sometimes at the point of transition of the needle from where it was parallel to the sclera and then it becomes parallel to the iris, there is sometimes so much of resistance, but a second instrument, if you could depress the limbus, it facilitates entry of the tube into the anterior chamber. And again, we all do agree that once you have the tube as far away from the endothelium as possible, that is a definite sign for long-term survival of the tube. It's difficult to, in this long scleral tract, sometimes it's difficult to prejudge the position where we have to make this transition to get the tube. You need the tubes to enter through the trabecular meshwork. You definitely want to enter below the Schwalbe's line. And this 23 gauge needle, actually this is 3 millimeters still here. The groove till here is 2.8 millimeters. So we make sure that the needle enters the scleral tract till this groove. If you have a sufficiently deep anterior chamber, this is a mental calculation you have to do before starting your scleral tract. So if you enter till here into the tract, a sufficiently deep AC, the tube gets into the chamber very close to the iris. Slightly shallower anterior chamber, you could probably go till here before you actually make the dramatic change to get it into the iris, get into the parallel to the iris. And if you have access to a wet lab, you could practice this multiple times to perfect this technique before you actually try it on the operating room. That's my last slide, and thank you very much.
Thank you very much, Dr. George. And as usual, that's an excellent presentation. All of us watching it always think that we could do it as neatly as you do. So with that, we'll move on to the last presentation of this evening. That's Dr. R. Venkatesh. Dr. Venkatesh, yeah. MIGS for the developing country.
We can play that, madam. I think,
yes. So, Bhageshwar, can you play it?
Good evening, friends. I take this opportunity to thank Glaucoma Society of India and Dr. Chandrima Paul, our secretary, for giving me this opportunity. So today I'll be sharing our experiences with minimally invasive glaucoma surgery. So as glaucoma surgeons, we are looking at something which is very safe, less expensive. At the same time, we need a quick recovery for our patients. So if you take MIGS at this point of time, who will benefit? Mild to moderate glaucomas, especially open-angle glaucomas. People with ocular hypertensive, who cannot tolerate medications. People with early glaucoma, but also they need cataract surgery because they have significant cataract. So we can add on a procedure which will be safe to them. If you take mixed at this point of time, you have subconjunctival drainage in the form of Zen implant, and the viable options which enhances the Schlemm's canal are trabectome, which is already there, iStent, which will be quickly available, Hydrus, GART, and Kahoot dual blade. When we think of suprachoroidal, CyPass is already gone off the market, and you have iStent Supra, and also ECP for ciliary body destruction. So viable options at this point of time is gonioscopy-assisted transluminal trabeculotomy, which I'll be discussing, and also I'll touch upon a technique called BAND, which is an alternative for Kahoot's dual blade, and also ECP, which is an option which is already there. So this gonioscopy-assisted transluminal trabeculotomy is again a good option for open-angle glaucoma, usually performed with an eye-track microcatheter, but we learned to do a less expensive way from the person who innovated this technique, Dr. Davendra Grover from Glaucoma Associates of Texas, and this is done using a 5-Prolin suture. And what you basically need is you need a low temperature cautery to kind of snub the suture. You need an MVR blade, you need Helon GB, you need an MST forceps, and also a McPherson forceps. So you can see this cautery is making a small snub at the end of the suture so that you don't damage the canal. Normally you need a couple of ports. One is the main port and the other is the side port. And if you're doing with a combined surgery like a phacoemulsification, your phaco incision can be the main incision. You introduce the 5-Prolin inside the eye, and then intraoperative gonioscopy is very important. You position the patient, see the angle, and using an MVR blade, you make a nick in the trabecular meshwork. You can see because there is blood in the Schlemm's canal. Once the canal is open, you can see some blood oozing. So you clear off the blood using Helon GB. And then you start threading the Schlemm's canal with the 5-Prolin suture. So this is very important. I'm using an MST forceps, which is very important, which has got a nice grip and hold. So you thread it 1 clock hour by 1 clock hour into the Schlemm's canal. And when you are crossing 180 degrees, there will be a little bit of resistance, but you can cross it comfortably in most of the cases. And what we are trying to do is trying to do a direct gonioscope in between to make sure that the suture is there. Normally in an eye-track catheter, you can see the light source, but here you can't see. You can do intraoperative gonioscopy to check it. So for that, you use a direct lens. And if you see here, it's crossed almost 300 degrees and it's come on the other side. You hold it with the MST forceps, and using a McPherson forceps on the other side, you pull the suture from the side port. So this creates the 300 to 360 trabeculotomy. The other option is the Kahoot dual blade, which will be available for us. It removes the trabecular meshwork, and it doesn't damage much of the surrounding tissues like how the other procedures done. So this is a very elegant way of doing trabecular meshwork removal and opening the Schlemm's canal so that you can enhance the outflow. And you can see there is a sharp tip which easily penetrates the meshwork, and the ramp helps you to lift and stretch the meshwork. And you can see the dual blade here, which excises the strip of meshwork. So it's so elegantly designed for the Schlemm's, to open up the Schlemm's canal. So the ram settles down on the wall of the canal, and then the blade strips off the trabecular meshwork, like how you see here. So the dual blade does a job of cutting off the trabecular meshwork and stripping it. So little bit of learning curve is there. Gonioscopy is again key. Once you see the angle very well, and if there is blood, again it will help you to identify when you have blood in Schlemm's canal. So you can do this 2 to 3 clock hours to enhance the outflow. The other option is the bent ab interno needle goniectomy. So can we do Cahook dual blade in a simple way? You can't have the same results like a Cahook dual blade, but it is feasible to do using this bent ab interno needle goniectomy. Basically, you 25 gauge needle, you bend 90 degrees here, the tip, under a microscope, and then again you can see nicely there is blood in the Schlemm's canal here. You identify, you peel off the trabecular meshwork because there is blood. I'm just putting a little bit of more of Healon GV to make sure I see things clearly. And then you peel off the trabecular meshwork like how you were doing with the Cahook dual blade. The same elegance may not be there, but practically it is possible. And we have tried in almost a dozen patients, and it works very well. And we do around 3 to 4 clock hours of this peeling so that the Schlemm's canal is open to the anterior chamber. So ideally, you open up the natural outflow to happen. So at the end, you can see a little bit of microhyphema, which has to be washed up. And if you see how this works, is basically, you know, when you start looking inside, when you start hydrating, and then if you look at the areas where you have made the opening, you will have a nice blanching of these episteral vessels. You can see this here. So this shows that the rest of the area there is not much blanching. So once you hydrate, you can see nice blanching in this pattern. This shows us how the natural outflows are kind of increased after doing this bang procedure. So the other important thing, or the most important thing, is to learn intraoperative gonioscopy. Positioning a patient is very important. Ideally, you have to put the head away from the patient, I mean the surgeon, and then the microscope should be tilted towards the surgeon. So you need something like a 30 to 40 degree tilt so that you can do intraoperative gonioscopy. So you need a Swan-Jacob surgical prism like this, and then you position the head properly, and then you start seeing the angle structures. So whenever you are doing a cataract surgery, like even a phaco, after completing the phaco, you can do this as a practice so that you are well prepared. And once you have these mixed options, you are prepared to do those. So definitely once you have these options viable, you can preserve the conjunctiva for future surgeries. And of course, it will definitely improve the quality of life. Again, I take this opportunity to thank Dr. Master Secchi.
Thank you. Thank you very much, Dr. Venkatesh. That was indeed wonderful. Excellent surgical skills and very beautiful presentation with the animations. So I must take this opportunity to tell you that all you wonderful speakers have actually taken GSI globally. And there is a question here from the lead of glaucoma services, NH Lanarkshire University Hospital, Glasgow, to Dr. Ankush Mahajan.
Yes.
His question is, how do you select which patients are suitable for viscocanalostomy?
Yeah, important thing is that it has to be an absolutely open angle. So if you see even a borderline open angle like grade 2 or barely visible grade 3 where scleral spur is barely visible, it is not a good candidate, because what will happen is that if you do a canaloplasty in a case like that, you will convert open angle into a narrow angle. The tightening of the suture will cause apposition of the canal to the iris. So it is important that the angle is absolutely open. For me, in Indian scenario, the best candidate are myopic young adults with glaucoma. So those are the people who are the best candidates for this kind of glaucoma, because even in older adults, I was doing canaloplasty 5-6 years back. But the thing is, I noticed in Indian eyes, after 3 years, the canal trabecular meshwork starts getting clogged with pigment. So in our scenario, pigment release is a big problem with canaloplasty. This does not happen that much in young adults. I don't know why. So the best patients I've had since last 5 years are the young myopic people who are doing excellent with these. And somehow older people, after 2 to 3 years, their IOP starts rising, and the most common thing I see in these guys is that the canal pigmentation is increased over time. So that's it. So you need to have gonioscopy. That is the sole criteria for deciding whether to do a canaloplasty or not.
Correct. And can we have any of the panelists comment on that as well? Yeah, Satyan, Shirish.
Yeah. Like what Dr. Ankush said, definitely the young ones will be the best ones. The older patients, as the size of the lens increases, there is always a kind of a rubbing on the iris. There is a pigment release. It gets into the trabecular meshwork. So that is one of the reasons why you have a very less pigmentation in the young people, and as the age increases, there is going to be an increased pigmentation of the trabecular meshwork in the elderly people. So definitely yes, we need to have a really wide open angles and do a proper gonioscopy. Don't mistake the pigmented Swalby's line as a trabecular meshwork. So that's very important to understand the anatomy before you do the viscocanalostomy.
Satyan,
yeah,
we will not take only early glaucoma, in a sense that non-penetrating surgery doesn't have good success rate in moderate and advanced. So
yeah, obviously,
we will not consider that as criteria.
Yeah, all the mix and even the viscocanalostomy mostly are the early glaucomas, not the moderate or severe disease. So I think that's an obviously known indication for the mixed procedures.
So, just hypothetical question that your young patient, early to early, let's say not moderate, and for some reason you decide surgery, will you consider NPGS or you will still do TRAB only?
That's a tough question to answer. As far as I'm concerned, I usually do only the trabeculectomy.
Yeah, I think this canaloplasty, since you're making the scleral shaft and detecting scleral prolapse, so is it really minimally invasive?
No. Nobody said canaloplasty is minimally.
Not minimally invasive.
No. And second thing, the question about doing it in advanced glaucomas. I mean, how many people you have a patient with, say, disc of one eye is almost gone, temporal vision. How many people are going to put in a tube or do a trabeculectomy risk in a patient like that? If you can decrease the IOP by 20 to 30%, even by using NPGS and then put patients on medication, what is the harm? I mean,
I think, Dr. Mahajan, in advanced glaucoma, the trab and tube have a much better success rate than NPGS. And I think all the glaucoma especially would agree with what I'm saying without any doubt. So I don't think that we should recommend NPGS, any form of NPGS even in advanced glaucoma at all, because the trab has a very, very safe profile if it's done properly, and that can be done by general ophthalmologist also. I'm not talking only glaucoma specialist.
Yeah, I agree with you.
I completely agree, Rajul, but at the same time, there are few patients where you feel the real threat. Definitely, there is a slight advantage in the viscocanalostomy by means of a safety little better than the trabeculectomy. So that's what I think.
In principle, I agree.
Yeah,
but in reality, in an advanced glaucoma, even with the thread, I think I would still do trab. We're taking little more precautions, and every patient will take precaution, but I would still go with the trab because I want more pressure reduction.
I think Dr. Shanta has a paper on that, right?
Yeah, the wipeout is very minimal. Yes, Dr. Shanta.
I completely agree with you.
I have a comment, because with NPGS, if you see, almost 40 to 50% of them need a laser sclerotomy. So ultimately it becomes a penetrating procedure. So if you look at long-term head-on comparisons with trabeculectomy, definitely trabeculectomy carries an edge. So I agree with Rajul that for moderate and advanced cases, you would prefer a trabeculectomy.
One correction.
Can I just add a point?
With NPGS, you don't need a laser opening later on because this is a procedure you don't want a bleb. So
right. We'll take Shirisha and then we'll go on to Sir Dr. Pandav for the last word. Yeah, Shirisha.
Yeah, well, just to make a point that for the similar indication that Ankush is talking about, we could, instead of touching the conjunctiva, you could do a GAT procedure. That would still help you because you have minimal reduction in intraocular, lesser reduction in intraocular pressure compared to a trab. At the same time, the safety profile is much more and your conjunctiva is untouched. So that could definitely be an alternative because until now the issue is that the iScience catheter was not available with us. But I think with the GAT, it looks really, really promising.
Yes, Dr. Pandav, sir.
I think while at this topic, I was just wondering, I think Dr. Mahajan had showed his procedure. It looks to me like a combined procedure. Is a canaloplasty and deep sclerectomy together.
No, so...
Or do you always do it the same way?
No. Deep sclerectomy is totally different. Deep sclerectomy is a bleb-based procedure where you want the fluid to come out. Canaloplasty, you don't want the fluid to come out. In a deep sclerectomy, you don't place in this catheter. You don't need a catheter. You don't place a suture inside the canal. So in canaloplasty, what you're doing is...
No, there's canaloplasty. I agree on that. But then when you're, doing a big scleral dissection, like you do for deep sclerectomy.
Yeah, so they are almost, I would say, the dissection is almost similar. Where I do deep sclerectomies also. And when I do a deep sclerectomy, I forego the catheter part and use very loose sutures. The flap is rectangular there, sutures are very loose. I put in 2 sutures maximum and let the fluid come out easily so that you will get a bleb, and you use mitomycin C with deep sclerectomy. With canaloplasty, you don't use mitomycin C.
Ankush, it was kind of almost like a deep sclerectomy combined with the canaloplasty, the one which you showed actually.
Sir, dissection is the same.
Yeah. Understand that, yeah.
Okay. You have placed a spacer too. So the Ologen implant was placed there, so it becomes very similar to a deep sclerectomy.
Kind of a combined, all combined.
Spacer is put in to prevent the superficial flap from collapsing onto the deep flap. This was a myopic patient, and in a very big dissection in myopic patients, sometimes you see anterior staphylomas happening, and that anterior staphyloma can close down the space between the flap, superficial flap, and the bed. So you put in a spacer sometimes in myopic patients so that the space doesn't close in, and there's a fluid lake between there that can help redirect the fluid from there into the ostium and back into the canal.
Okay. So we move on to a question. Here's a question for Dr. George. I have used this technique talking about the patchless tube implant, but there is extreme thinning after 5 to 6 years. I wonder if similar thinning may happen in deeper layers and may melt the deeper part of the sclera and maybe the choroid. Your opinion?
No, as I was mentioning, it is important to have a scleral tract of adequate depth and length so that the tube is well embedded in the patient's sclera. I think once the tube is embedded in the patient's sclera, there is so much of less elevation of the ocular surface, much less inflammation and such, much better wound healing response. But I definitely don't have post-operative results till 5-6 years. So we will have to wait and see, but the healing is so good, the sclera is so intact over the tube, I suspect they're going to stay the same way. It is just that the sclera, the donor patch graft you use, that can melt in due course.
Yeah,
but
actually, just to add that the tunnel part of it, that tight tunnel is the key in this actually. Yes. Otherwise, if there is a micro movements, that's where you get into this more problems. Like earlier in the video was essentially that the track has to be really tight. If there is a micro movement, then you really have this issue.
Once you have a 23 gauge track there is hardly any micro movement there. It's a snug fit.
Yeah, that's what I'm saying. If you are just to make the track little wider, then you have the problem. That's what I'm trying to say.
It can be a little...
Dr. Putran, sorry. I think please go ahead, Dr. Shant.
I just wanted to make a point that it's difficult to fashion infantile glaucomas with very stretched and thin sclera. Don't you agree, George?
Yes, ma'am. But I still feel even in age group less than 1, no, we have been doing this. We try to get about 50 to 60% of scleral depth, and we see that the healing is so much better at the limbus, even for children less than 1 year old. Nowadays, to tell you very frankly, I am more worried if I have to keep a patch graft than to get this tube through the patient's own sclera. It is difficult. If there is a learning curve, the issue with the infantile glaucoma is even after threading the tube through the scleral tract, there is slight anterior movement of the tube. However well you get it iris plane parallel, ultimately the tube goes. But the key here is to get the entry as close to the iris, so that later on during your 3rd or 4th postoperative month, sometimes we just go in and trim off the tube. The tube stays very close to the iris, and there's hardly any movement of the tube. We have faced problems, other problems like tube lens touch, tube corneal touch. Even the other paper also described the same thing, but we have not had a tube exposure in a child, which is remarkable.
George, can I ask a question? So yes. 4 millimeter track is fantastic, but why can't we make it 6 millimeter? I have seen a couple of other videos where you make a 2 millimeter posterior tunnel, you make a cut, and then you have a long tunnel which is placed anteriorly. So the idea is that the entire length of the subconjunctival tube is kind of covered. While I agree that anterior part has higher chance of erosion because of the lid movement and the lid contact, the posterior area is usually less problematic, but would that help, or a 4 millimeter is sufficient? Because there are a lot of people, other people who are also part of this group and meeting.
Yes, Risha, I definitely agree. The longer the scleral tract, the safer it becomes. But it is not very easy to fashion a 6 mm scleral needle track to get your tube into the anterior chamber. It's really challenging. But if I get it slightly above 4 millimeter, nowadays I'm very comfortable, and I can see that the sclera is totally covering. And usually all these tube exposures usually occur within 4 millimeter of the limbus. It hardly ever occurs much more posterior. So it's the 4 millimeter part which we have to cover.
Also, George,
put a suture to flatten the posterior part of the tube, because before there has to be some elevation of the tube.
Yeah, that is done initially before we fashion the track. We have a non-compressing box suture very near the episcleral plate, and what it does is it prevents lateral mobility of the tube, and also after you place that suture, the tube obeys the contour of the globe. That is done for every case.
George, what would you advise for conditions where you feel that the sclera is not in the right place? I mean, there is some scleral disease which could happen in the future.
For a scleral track, Venkish?
Yeah. So if there's something like a sarcoid or some secondary glaucomas wherein you think sclera can melt in the future, would you still do the track or you put a patch?
I think for such kind of inflammations, even if you place the flap corneal patch also, that also will melt. So I would still prefer to put in an adequate depth scleral tract to put in the tube.
What are the chances of doing it in the inside, migration towards the uvea tissue?
Towards the uvea?
Yeah.
See, ma'am, while we fashion the scleral tract,
the same compression and pressure at the bed may allow it to melt in that area, because sclera could be thin in many patients.
That is a possibility, but I think
in one case in my lifetime that I have seen this tube inside.
The key here is to get it initiating the track is about 50% scleral depth, And as you go forward, you make sure that you're seeing the needle through the microscope. You're just seeing it. That is the key. So you have 50% depth of the sclera.
Yeah, and George, we are doing for last 4 years now, and I think I totally agree. The tube exposure is literally zero. But the question Venkatesh was asking, the thin sclera, the inflammatory, have you tried cornea rather than scleral patch graft? The corneal patch graft.
Yeah, we used to keep partial thickness corneal patch graft in all our cases earlier.
Yeah, because I think that works better than the sclera. The melt is much less with the corneal patch graft rather than the scleral patch graft.
Probably.
Good option when in the COVID time it's so difficult to get the donor tissue.
In my practice, I would like to comment. What I am doing is I am using the partial thickness scleral patch of the patient only. The partial thickness scleral flap, the way we make it for trabeculectomy, the shape is just 6 by 4 mm size, and I introduce the tube beneath it, so I don't need any donor scleral graft. It is the partial thickness scleral flap of the patient itself. And I have not seen any tube exposure in my experience. So far, I must have done more than 50 cases with the same technique. No tube migration. The only thing I do is I apply 2 sutures, and they are very tight sutures. Even I don't tie the tube also. But so far, I have not experienced that frequent tube exposure. Secondly, even the thing that we get with the donor scleral graft, the elevated area over there, so those things are also minimized, and I am getting good results with this particular technique. And in this COVID era, when we don't have any access to the donor scleral graft, this technique is very safe in my hands. I think a few of you might be using the same technique. You might be using the same technique.
Yeah. Anuja, right time you move on to the track because you are already doing it. Now it's an additional flap construction, so you can save time. At the same time, save the sutures also.
And beneath that, my needle track is there, just 2 to 3 millimeter behind the limbus. So the tube is covered till 6 millimeter from the limbus.
It's true. You move on to a track.
Anuja, the advantage is the ocular anatomy is as less disturbed as possible in the track. Here again, there is slight elevation of the scleral flap. Whatever scleral flap you make and put a tight suture.
George, how do you prejudge the entry point? Because that's very important. Where do you really start dipping your needle? Because when it's a long needle track, it's a bit difficult to get the correct entry into an anterior chamber. I think that is the point which needs more learning, I would say.
I totally agree. Extremely important. I think all of us would agree that having the tube as far away from the endothelium is the most critical part of the tube surgery. So that's what I was mentioning. Initially, we tried to keep the 23 gauge needle above the scleral tract and have a mental calculation, depending on the anterior chamber depth, how much of the needle should enter into the scleral tract, after which you abruptly change it into the iris plane parallel. So what we did was, we are using a 4 millimeter scleral tract, and we tried measuring the groove of the 23 gauge needle. So there is a groove which is about 2.8 millimeters, then there is a slight slant which is about 0.2 millimeters, and then the solid part of the needle starts. So it is anywhere between this groove ending and also the solid part beginning. That is where once the tube enters the track that much, you have to just blindly, dramatically change your position to get into iris plane, because again, once you prejudge that point, and if you have crossed that point and you try to enter, you become more into the cornea. You have to take that risk. It is anywhere between 2.8 to 3 millimeter of that needle.
And what I do is that I kind of define the scleral spur. So where the scleral spur likely to be there, and you start dipping your needle just before you reach the scleral spur. So basically, you are going a little bit to the superficial aspect of the the sclera, above the scleral spur in that area, so that when you go dip down, you end up in the middle of the temporal meshwork, and then you straighten the needle. So
the only issue is it is an opaque area. For beginners, this might be an added tip to prejudge where to dip.
Yeah, where the scleral spur would be, approximately.
Any advantage of just rotating the eyeball downwards or making it horizontal? How do you prefer to do that?
Initially the eyeball is a little downward, rotated downward. Once you reach that prejudged point of transition, that is the point of scleral spur, you have to grasp the cut edge of the conjunctiva and slightly rotate the eye so that it's facing straight rather than downwards. It's facing straight up. And that is also a position where the surgeon can clearly see the needle entering the anterior chamber.
Exactly.
Very close to the iris. That's very, very crucial. Grasping the cut edge of the conjunctiva and slightly rotating it at the maneuver of dipping into the anterior chamber.
Excellent. Sushmita would like to add anything?
It's like what George was telling also is very, very useful. Now, once you get a human eye, you can do even 10 or 20 entries at different points. Fill it with visco and then make sure the trainee does it at different points so that they get a feel of it.
It makes a huge difference. It makes an absolute huge difference. That's the game changer. A wet lab training.
Yes.
So Rajul, when you are doing the needling, when you see the conjunctiva is little congested, would you like to use the brimonidine drops or adrenaline before you start doing the needling so that your bleeding and the congestion is much lesser?
So sometime I start the low dose topical steroid before, a few days before the needling. I have not used brimonidine, but I think your concept is good because it would cause the vasoconstriction.
Yeah,
so I have not done that.
I have not
done. So you can elaborate what are you doing.
Yeah, on the table I use brimonidine before we do even the trabeculectomy where you see a lot of.
So how many minutes before the needling?
No, I'm talking about the trabeculectomy. When we are doing the trabeculectomy, when you see the conjunctival lot of filiform vessels, just apply the brimonidine. It just takes about probably a minute or so. It just completely blanches the conjunctiva. Yeah. And then you can go ahead.
That before trap, if the conjunctiva is congested, there's a congestion or something, I usually start low dose topical steroid a week before. And that works very well.
In some cases, you still have the quite a bit of a congestion.
I think I agree. It's a good idea.
Yeah, I would agree that on table we definitely use it. Suppose you are giving a block, immediately after the block you can apply 1 or 2 drops. Otherwise, on the table, even after we drape, we can do that. In fact, our squint surgeons do it routinely, and they find that the bleeding is much less. So if they are using it, then we can use it as well.
I use it as a routine in most of the cases, so that the bleeding is much lesser.
Yes.
I also use steroids starting 1 week before, especially if the patient has been on multiple anti-glaucoma medications to make the conjunctiva less inflamed. I think it has become now a routine practice to use steroids at least a week before.
But Sunita, that would definitely run a risk of pressures going up, and in glaucoma patients, if we ever take them for surgery, these eyes are really difficult eyes where, even
but if the pressure is too high, then...
Teresa, the low dose steroid causing IOP, steroid response within 5-6 days is very rare. It's very rare. Usually it will take few weeks for the IOP spikes to happen.
If the patient has been using bimatoprost and all, so conjunctiva is really in a very bad state.
How much are you going to change in these 4 or 5 days is my question.
And
I have seen,
inflammation.
Yeah, I have definitely seen steroid response happening in these patients, in predisposed patients, even in 2-3 days time. So I'm not saying it could be a good idea, but for people who the patients may not come back for follow-up. I can give you an example of a patient for whom a PG analog was stopped 1 week before the surgery, before the glaucoma surgery. Patient was asked to continue the rest of the medications and put on low-dose steroid. Did not get a fitness for surgery because his sugars were very high. Came back a month later. So while we are talking to the general people, I think we also need to be very clear about it that yes, 2-3 days before or 4 days before you may start a low-dose steroid, but we need to be very, very careful when we advise that, how long and what is the dose and how much of a difference does it make in your patients. I just wanted to make that point.
Yeah.
Even when you're using low dose steroids like fluoromethanol or loteprednol, the risk of IOP elevation is definitely there. So we should not be in our comfort zones that since we are using low dose steroids, the IOP elevation is not going to be there. We must have our guards well up, and we have to actively see for a steroid response. Because I've seen patients on putting loteprednol having 40-50 pressure, so it can happen. It is not rare to not have an IOP elevation with a low potency steroid. So always keep that in mind.
I think one can just add in pre-operative notes and
once
give
you have finalized the surgery.
Yeah, once you have finalized, you just can't give it like that before finalizing the surgery. So when you are sure that patient is going to get operated in a week's time, and give systemic acetazolamide also if the IOP is
necessary.
Yeah.
May I ask Santa ma'am one question?
Yeah.
All of we are using mitomycin C intraoperatively. I think now some of us have shifted to subconjunctival injection. Now, exactly how much before surgery actually we should inject the mitomycin?
I think just before you make the conjunctival incision, you inject the mitomycin, make sure that you spread it posteriorly and keep it for 1 minute and then open up the conjunctiva.
So
once you open up the conjunctiva, you have to use a muscle hook to apply some pressure on the tenon so that you get the mitomycin C out.
You personally use subconjunctival injection or?
No, I don't use subconjunctival injection because I'm worried about the dosage, but the concentration used is far less than what you use for sponges. So we haven't started using it, but this is a technique that has been described, that you inject away from the limbus and you use a muscle hook to tease the mitomycin out of the tenons.
Because some literature says
low
that
concentration, and you open the conjunctiva after 1 minute.
Because some articles say that you inject it once the patient is inside the OR, not on the table. I think what you have said, that is also usable.
No, I think you have to inject it just before you start the surgery. Don't inject it earlier. Definitely not.
Anything else? Dr. Vairi, you want to add something?
Do we have any more questions from the audience?
No, we don't have any more questions.
May I ask just one small question to Dr. Susmita. Susmita is there?
Yes, she's here.
Can you give us some tips, especially in bleb division cases where you put a scleral patch? Because many of these cases we see that after the scleral patch is applied, the IOP goes to the other side. It becomes very high. So any tips you can give to the participants or the audience so that the IOP remains normal? Any special tips? Scleral patch in bleb division, any specific way of putting the flap, number of sutures?
So sometimes the mitomycin does not just cause havoc to the conjunctiva, it also acts on the sclera. So that's why I keep that in the OR. And sometimes we see once we've cut off this necrotic tissue, there's actually a uveal show there, and that makes me very scared to just cover it with conjunctiva and nothing else. But when I use scleral flap, as you said, when we used to use it earlier, sometimes the pressure would rise. So now I use it as for a scleral flap, and the posterior ones are releasable. So that gives me some sort of control. So the two flaps posteriorly are both releasable, and it's only the anterior flap which is permanent. So it actually is like a normal scleral flap. But on table, because most of them are 1 or 2 pressurized, so on table I want to see the pressure built up, and they're taken up when they have macular striae and all that, so I would like the pressure built up. But normally there is a little bit of control that I have, and it works well as for a scleral. But if I don't see an obvious uveal prolapse, just covering it with healthy, viable conjunctiva works well. I don't need to usually do that. The only problem sometimes which I face is if the area is very, very large, then no matter how much you undermine, you can't get conjunctiva over. So one small tip of that is I make a little bit of a horizontal fornicial incision into the conjunctiva. And then when you pull it down, actually the area in the fornix is so well vascularized, it heals beautifully. It epithelializes well. And that little bit of a defect doesn't really matter. But you have to be careful that you don't incise tenons at the same time. So if you just incise the conjunctiva a little bit, that gives a little more play with which to do it. And touch wood, till so far that I haven't had to use a conjunctival autograft or something, which I find doesn't do too well. And just a comment about the MMC, that when we do the ab interno, again, Dr. Devendra Grover has popularized the technique, and we use mitomycin, but his technique says to use it about almost a week or 4 or 5 days before surgery. 0.01, 0.1 cc or 0.01 ml MMC in the fornix and spread out across with a Q-tip. And then there, so when we plan them for surgery, about a week prior, we give this MMC, which stays there for a week. So probably in 4 or 5 days, it acts there and it does better. Because I would be very wary of using MMC on the table with an ab interno, because then it's going to go straight in, because you've opened up everything. So maybe that's the reason why they say you have to keep it at least 4 or 5 days prior to surgery, let it equilibrate or something, and then do it.
In ab interno, actually, I did few cases, 3-4 cases I did. Initially, for a few months, the bleb was okay, but subsequently, bleb was not very good. How it happens in your hand?
Mitomycin?
I use mitomycin C once only, after I do the needling part. At the end of the surgery, I use mitomycin C. But anyway, somehow the bleb did not survive for too long.
We have about a year's follow-up now of, I think, 14 and 6 months of about 25. And it's worked in about 2/3 of them well. So for me, it works in about 2/3 if I've avoided everything else, resurgery, needling, everything. That's how it is so far. But I still have to go back and see which are the ones which worked and which are the ones which don't. But my intuition would be that if you do it a little earlier, maybe you're a little better off rather than when it has really, really scarred down.
And the surgery is really tricky because the anterior chamber tends to become very shallow during the procedure itself. So we have to keep on injecting high viscosity viscoids. Okay, thank you.
The other option is you can do with an AC maintainer also. So that will be a very safe option.
Yeah.
I think when the bleb is failing, or is a failed, there are a number of options, are available. You could do needling external, you could do, ab interno, you could do a limited revision of the bleb or a retrap. I mean, how do you decide what you want to do? I think I'll put it to the panel, maybe, have their views. How do they choose the procedure for, this situation?
Let's start with Satyan. Are you there?
Yeah. So needling, for me, if I have to decide to do a needling, I need to be able to see the edges of the scleral flap. If that is visible, that means if the conjunctiva is flat and the edges of the scleral flap are visible and the internal ostium is patent, then needling works, whether we do an ab interno or ab externo. So a revision is something that I have actually for situation where there is hypopnea rather than for failed blebs, especially if the pressures are very low. Sushmita showed very elegant technique of the compression sutures, but I'm very skeptical. I just don't like to do anything with the conjunctiva over it. Maybe that is my fear. So I generally tend to make an opening in the conjunctiva about 4 to 5 millimeters away from the limbus, tiny little opening, and then go to the area where where you have made a flap. Go there and place 1 or 2 additional sutures to the scleral flap, and we can just close the conjunctiva with Vicryl. We can do that with topical anesthesia also. That should not be a problem, and it's a definitive procedure, and I just leave the conjunctiva open there. So these are the 2 things that I would do to...
Just to mention, sometimes I do a similar procedure for high pressure actually, not for the low pressure.
Yeah.
You go a little posteriorly, make a tiny opening there, and through that you dissect, go under the scar tissue and lift up the flap, because the scar and the flap is usually, is kind of together. So you lift up the scar, the flap also comes off, and you can re-establish the exit. Of course, the ostium has to be open. So sometimes that also works. So there are a number of procedures described actually, because all surgeons, they face this situation and they have their own ways of dealing with it. So that's why I put this question, how do you choose what you want to do? I mean, like for me, if the flat is totally flat, if there's no aqueous coming into the subconjunctival or subtenon space, and if there's not much of a scarring, I'll probably go ab interno, and like Sushmita, showed you the. So you go from inside and then you open up using, the Grover spatula. And but if there's a fluid coming through, around the flap, and there's a problem in the subtenon space, then probably the conventional needling might be more appropriate in those cases, because the fistula is patent and the flap, the partial thickness flap is not really obstructing the flow. The problem is in the subtenon space or the subconjunctival space. So there you could probably do it the conventional needling that we described, or basically break that tissue. So I think sometime we do UVM to find out whether there's any fluid lake under in that area or not. So you just drain that fluid lake into the healthy area.
So now that we have the access to the CASIA, that's a very, very good modality to look at the blebs. The earlier ASOCT would make it a little tricky, you weren't really sure, but in case there's a CASIA, of course you can do it with the serous ASOCT also, but the patient needs to move a little back, and it's a little tricky getting it. But the CASIA has a bleb analysis thing, so they've configured their OCT to be able to image the area on the sclera. And that has given us a lot of clues. So like Dr. Pandav said, if the scleral flap is completely flat, then there's no question that a subtenos needling is going to work. So that's where we do an ab interno. But if there is fluid under the scleral flap and the scar is beyond it, then that's our main way of deciding whether to lift up the scleral flap or not. But ab externo, at least I am very scared of going underneath the scleral flap, so I wouldn't do that. I find that too blind to go in. So ab interno is all right, but that's one tip that we do. We use the ASOCT a lot on these blebs before intervening. And of course, the sclerostomy has to be wide open. That's the first thing.
What I say, because so many general ophthalmologists are listening to us, don't take needling as a light procedure.
Yes.
I think it should be done by the specialist. Secondly, do the excellent counseling before you attempt the needling. Patient has a lot of expectation. So tell them it might need a repetition or you might need some medication. Don't expect it to be 100% successful. And mitomycin C injection, one has to be very careful. Just don't do it if you don't know how to use it. That is what I would like to share.
Wonderful. So we had a wonderful discussion, and we'll draw the curtains if that is it. Thank you very much, all of you, for your wonderful presentations and your wonderful inputs. It was really a great evening, and I would be failing in my duty if I do not thank Microlabs, Sun Pharma and Santen for making this possible for GSI. We look forward to having you again very soon. Till then, thank you very much. Good night.
Good night.
Thank you very much. Thank you. Good night.